I can't say good morning because it's nowadays the mornings are not very good. I will just say morning,
Yeah.
and we should hope and pray that things improve. We have a wonderful speaker, Dr. Prince John, a good friend of mine for a long time. He is qualified in palliative care in the aged, which is, I think, very important, neglected area. And of course, he did the certificate in palliative medicine from Cardiff. Uh, Years of experience and runs and is the medical director of Palex Healthcare, which is to integrate palliative care, geriatric care, and long-term care. I think that is something that palliative care professionals must pay attention to, and I think it's an excellent subject for us to listen to from a person who has been working in this area. And thank you, Prince, for having agreed to our invitation. And you might please start with your presentation.
Thank you very much, sir, for giving me this opportunity. And I thank IAPC also. Yeah, so like I said, is a very dear topic to me about how we can integrate palliative care with geriatric and long-term care. So basically, what I would like to do in this presentation is just go over what each of these components are: geriatric medicine, palliative care, and let you know as to how we have tried to integrate it in our setup. Uh, so basically, as everybody knows that geriatrics or geriatric medicine is a specialty that focuses on healthcare of elderly, and basic aim is to promote health by preventing diseases and disabilities in older adults. As all of us know that the elderly are in a physical place by the time they're 60, that most of them have some comorbid conditions. Most of them have one or two comorbid conditions. Some of them have disabilities, physical problems, and so on. So geriatric medicine per se is a specialty that takes care of each of this. Then we'll come to long-term care. So long-term care, basically, if you look it up, the definition varies from various sources depending on where you're taking it. It is a variety of services that helps both as medical and non-medical needs of the people with chronic illnesses. So the basic aim is to make sure that we can promote independence, maximize patients' quality of life, and meet patients' need over a period of time. And in long-term care, specifically, if you look at Indian context, it refers to, to provide a continuum of care, like we have learned in palliative care, to provide that care continuum to medical and social services designed to support the needs of patients living with chronic conditions. So then we come to geriatric palliative care, which is interspeciality, which basically helps collaborate and pick up the best of geriatric medicine and palliative medicine to apply the principles of palliative medicine to respond to that unique situation which I was talking about, wherein we are trying to provide the optimal care and optimal quality of life to elderly. And these elderly, like I said, could have severe life-limiting conditions as well. So there is this interface. So when we started thinking about geriatric palliative care in India, we realized that it really doesn't exist as a specialty. Everyone knows that palliative care has been growing leaps and bounds in the last few years. I would say the last 5 to 7 years, and more people are taking interest in palliative medicine, and which is a very good thing. But at the same time, knowing India and seeing how the population trends are, I think it's high time that we as an organization, as individuals, as specialists should look up and make sure that geriatric palliative care component is also something that we should be focusing on. Like pediatric palliative care, I think of late has been taken off very well under the leadership of Dr. Gayatri Palat. We would like, I think IAPC as an organization also should be thinking about taking up geriatric palliative care as an area of interest, because as I will show you, the data says that as the years are going by, there will be more and more elderly people, and eventually all of us are going to need geriatric palliative care. So, like I said, when we were thinking about how to go about setting up our organization which we work for, in which wherein we are trying to integrate palliative care, geriatric care, and long-term care, we realize that there is an interface that we have to that nobody is looking at this moment, you know, and we realize that in aging societies like India, the last phase of people's life, you know, when they are in, you know, after their 60s, it's quite challenging to the traditional care model which is available right now. Yeah, so most of the hospitals and the healthcare facilities are really focused on acute care, whereas the elderly are facing chronic conditions, and their needs are different. Their physical needs are different, the psychological needs are different, spiritual needs are different. So we have to, you know, that's where I realized that, you know, when I took up this course about palliative care in the aged, I realized that, you know, geriatric palliative care is really important, and how we can use the, you know, interdisciplinary model, multidisciplinary model of palliative care that we have learned, and how we should integrate into geriatrics, and how we can you know, provide the best possible care for the elderly. So therefore, like I said, that and again, the big area that lacks in India specifically is research in general about palliative medicine. But geriatric palliative care, I think the research is really on the lower side. So that's something that, you know, that's again something close to me, research. And I think as a community of specialists and practitioners of palliative medicine, people of similar interests to come together and join their hands and, you know, get into research. So just to give you an overview as to what's you know, basically the numbers we are talking about. Yeah. So when I started looking up the data for the elderly, and what it would be 5 years back, maybe 5 years later, 10 years down the line, 20 years down the line, this is the data that I could pull out. Now, this is the data that I have taken out from something called uh, the old age watch. Yeah. So what they say is that the number of people with age above 60 in 2015 consisted of about 12.3% of the total world population. By the year 2050, this is anticipated to become 21.5%. Now, as far as this is, you know, in context to the whole world population. When it comes to the Indian population per se, the percentage would be much higher, because what is happening right now is all the baby boomers, you know, that were considered uh, to have the best possible of healthcare and everything, are becoming 60 plus. And therefore, what we are seeing right now is a growing number of population of people who are 60 plus, who are physically active at the moment. Some of them would have good financial resources to take care of themselves, but at the same time, most of them have a lot of comorbid conditions and a lot of illnesses. So this is the Global Age Watch Index, which I was talking about. This is where the data came from. And Global Age Watch is an international organization. They basically look at how, you know, the quality of life for the elderly. And they basically look at different domains like income security, health status, capability, you know, whether the government is providing an enabling environment, whether the society is providing a good environment for the elderly. So the data that I have right now is, I think, from 2018, which talks about India. I looked up the latest data. I couldn't find it for India. They keep updating their data from for various countries over the years. So out of all the countries, India kind of ranked 71 at that point of time, 2018, I think. So this is not good, because countries like Bangladesh and many smaller countries, Bangladesh, Bhutan, and stuff like that, Nepal, they ranked much higher than India when it came to how we take care of our elderly, or how the elderly feel, or how the health healthcare of the elderly is taken care of in our country. So this was something that really hit us hard when we started thinking of how we could kind of integrate palliative care into into an acute care setting, or even a long-term care setting. And this is primarily the reason why we chose to work in geriatric palliative care more than adult palliative care, which we also work in, but our main focus is on geriatric long-term care. So you could see some other data indicators that we see on the screen. The life expectancy of the population above 60 has increased over the years. I have some more data here. Yeah. So like I said, the aging population in India is rapidly growing. The life expectancy at birth as a whole is around 66 for men and 69 for women as on 2017. This is the general data that is available. But out of that, healthy life for men is about 53 years, and for women is about 54 years. So this means that a lot of these elderly people will be spending their last years in some kind of illness, some kind of chronic illness, not one, maybe two at times, along with some kind of disability. Now, this is not good. This means that most of the people will be spending their last few years uh, suffering, and the intensity of suffering can vary from mild to really severe, and really bad. So thus we saw that people who make it to the age of 60 can live for another 15 to 16 years, but at the same time their resources would be much less if you look at the entire population. So when one retires at 60, one would have to have enough resources to support himself and or his spouse, and the near and dear ones, medically, financially, socially. And that's a big ask, because everyone knows that healthcare is expensive. And unfortunately, like I said, in India, not everybody has social security. There is many people don't have pension. So around only 10% of the workforce is covered by some kind of a pension. So it kind of boils down to how much savings these elderly have, and what is the cost of healthcare to them at that point of time. And over the years, everyone knows that the cost of healthcare is exponentially increasing, I would say. So therefore, this is a ticking time bomb that is waiting to explode. I believe that it is already exploded. Many experts feel that it's something that is about to. But like I said in the beginning, I think it's very important for us to look at these data and start noticing, and make sure that we are doing something about it. So again, some context that I would like to put in is about 15 years ago, 20 years ago, our family system used to be like a joint family. We had multiple generations of people staying together. So, the elderly were kept active. Even though they were retired, even though, they were at home, they were kept busy by, with their grandchildren, children, something or the other. And many of our grandparents kind of commanded the kind of the position of the head of the family for a long time, and in fact till they die. But now coming back to the current situation where it's nuclear families, two children, maybe not even two in some families, and so the joint family concept is kind of withering away, and it has a lot of consequences to the patient, to the elderly, basically, not financially but emotionally and psychologically. And this is something that we see as a big problem in our patients when they come to us. So there is a pressing need to pay attention for the well-being of the elderly. Diseases like Alzheimer's, Parkinson's, and dementia is increasing. Somehow we are seeing more of that these days. You go back 20 years again, like I said, we wouldn't see people with Alzheimer's or Parkinson's in that much percentage as we are seeing right now. And that therefore, and people are saying it's because of the changing lifestyle, it's because of the diet that we are taking. So what's happening right now is, this is what I believe, is because of our changing lifestyle for the last 20 years or so, we have kind of picked up a lot from the West, and we have kind of left a lot of our older beliefs and older systems and older ways of life. And that's basically causing us to shift to a position where we are becoming more and more sick, and we are becoming more and more frail as we are growing older and older. Yeah. And then it comes to our healthcare infrastructure. Now basically COVID has brought a lot of attention to the healthcare infrastructure of our country, and the vast variation of primary healthcare and rural healthcare available. And unfortunately, we need to realize that a lot of our aging population stay in the villages. They don't stay in the cities, which means that there is no good healthcare available in the rural areas. So this is some data from the Indian Journal of Community Medicine that I could pull out, and this is quite stark, quite unsettling to me, is because the data, the points that you see here, is 75% of the elderly population is living in rural areas as of now. 48% of the elderly population is women, of which 55% are widows. 73% of the elderly are illiterate and dependent on a physical labor for day-to-day living. One third of the elderly population is reported to be living below the poverty line. 66% of the elderly are in vulnerable situation without food, clothing, shelter. And about 90% of the elderly are from the unorganized sector, which means they don't have a regular source of income, they don't have pension, they don't have savings enough to take care of any healthcare needs if it happens. So coming back to why integrate principles of palliative care and geriatric care. So geriatric palliative care, like I said, it's a specialty which again talks about interdisciplinary approach of care, multidisciplinary approach of care, like we speak in palliative care. But here what our focus is, how we should really integrate more within the hospitals, and try and provide chronic care to the elderly from acute settings, which means if you have an elderly patient who's had let's say for example a fall and a fracture, and post fracture, everyone knows that if the physio is not given properly, they still remain pretty much disabled. So what we do in our current setting is we have integrated ourselves into acute care hospitals. We have integrated ourselves into organizations which provide long-term care. We have integrated ourselves into old age homes. So we can provide our expertise of palliative care to these elderly wherever they are. So I'll be talking about that as to how we have done it also. So the older adults, like I said, are in a unique place, physically, mentally, emotionally, where their palliative care needs are quite different compared to how we see in general adult palliative care or pediatric palliative care. Like we see see a huge difference between the needs of children and adults being very different. It's the same way how we see in our practice that the needs of the elderly are very different. Their spiritual needs are different. Their religious beliefs are quite mature. Their physiology is different. So, we see a lot of different reactions to medicines, which generally don't cause much problems in adults. So we have to, we have to integrate our knowledge of palliative care, avoid polypharmacy and things like that, which is a huge problem in the elderly. This is something that I feel that if the elderly kind of go to one doctor and sit with them and tell them all the medicines that they are taking, we will be able to, do away with a lot of polypharmacy. Unfortunately, because of the fragmented healthcare that we have in our country, one specialist doesn't speak to the other specialist. One doctor doesn't know what the other doctor is prescribing, and so so the elderly are many a times put in situations wherein they could have avoided a lot of medicines, they could have avoided a lot of things, and therefore avoided a lot of complications. So again, why integrate? Because hospital-based palliative care, again, interdisciplinary teams can take many forms and provide high-quality, goal-centered care for elderly and their families. So these were the three main points as to why we kind of jumped into geriatric palliative care. We realized that nobody is doing it, at least in Pune. I'm sure people are doing it elsewhere, but in Pune there was no organized a place where it would be like a one-stop place for the needs of the elderly. So this is again some just to give a context as to what where geriatric palliative care comes into picture. So like everyone knows, there is pediatric medicine, adult medicine, and geriatric medicine. Anybody above the age of 60 is considered 60 to 65, depending on which country we are looking at the data from. They consider people to be in the geriatric age group, and up there you can see here, just like pediatric palliative care, geriatric palliative care is very important. And when it comes to palliative care, and when it comes to geriatric specifically, because the patients are suffering from a lot of chronic conditions, and many a times they are present, the patients are is suffering from that condition for years and years together. uh, the patients present to us with clinical scenarios and symptoms, which is quite unique. It's not something that we see commonly in adult medicine. So coming back to what we do now, Palex Healthcare, like I said, is something that I started about 3 years ago, 2.5 years ago now, with a couple of my friends, and we thought of integrating palliative care with geriatric care and long-term care in both acute care settings and long-term care centers and old age homes in Maharashtra. Now, and the reason why we are focusing on all spectrum, because we see patients everywhere. Like if you see Pune, Pune is, everyone knows Pune is like a retirement city, and so we have a lot of elderly in Pune. I'm sorry, not of elderly in Pune, who are who had good life, who have had good quality of life till now, and they have chosen to retire in Pune. Many of the elderly that I meet were originally working somewhere in the north, somewhere abroad, some other part of the country, and then they have come back to Pune to relax and have a good life. But what we saw was, when there is some medical need, it all boils down to which multi-specialty hospital they go, and how the treating team is taking care of them. Not that we lack healthcare facilities in Pune. We have excellent hospitals, excellent private hospitals, two of which I'm associated with. But there was nothing that was looking at the needs of the elderly in a holistic fashion. So luckily, when I started this initiative, I got attached to a couple of private hospitals. One of which is Dinanath Mangeshkar Hospital, which is quite a big multi-speciality hospital in Pune, and they have had palliative care for cancer patients for the last 10 years or so. My colleague Dr. Sonali Sahu was there, and she has developed palliative care majorly in cancer. But once I started going in with the help of Dr. Sonali, we have basically trying to get into the other specialties. And with Dr. Sonali's help, we have been able to get into people who are doing practicing geriatric care. We are linked up with people who are doing neurology, who's nephrology, and so on. So we're getting a lot of referrals now from these specialists who really have understood how we are helping patients, and how we are cutting down on polypharmacy, and how we are cutting down on unnecessary medications, counseling, and giving them support. And therefore we are seeing a huge shift in how how they're visiting the OPDs as well. The number of visits have gone down. People are much more happier at home. They panic less. They don't come running to the hospital if there is some fluctuation. They don't get their blood tests and investigations done that often. So these are the things that we are seeing now after 2 years of working hand in hand with various specialists and various teams. And so what we do basically is provide inpatient palliative care in these hospitals. I also have a small setup of my own wherein we do specialized palliative care. I have a team of doctors, nurses, and healthcare workers who are specifically trained by me for geriatric palliative care and palliative care in general. And we try and provide all the good principles of palliative care that we have learned over the years, that we have picked up, and which are more socially relevant, culturally relevant, and try and provide that kind of care and expertise to the patients. So therefore we have services just like any other palliative care service in India. We provide inpatient care. We have about 14 beds now. We used to have 24 beds. We've scaled it down because of COVID. We have outpatient care. We have home-based care, and we have care for, and this is available both for cancer patients and patients suffering from non-communicable diseases, which means diabetes, hypertension, chronic renal failure, congestive heart failure. A lot of patients with neurological problems, Alzheimer's, dementias, they come to us, and we are trying to provide care to them. So, these are the services that basically we have evolved over the last 2 years. Like I said, this is more culturally relevant and relevant to the society that we are placed in right now in Pune. And we are trying to develop models and, units, hopefully in the future, wherein we are able to provide services that are more relevant to the elderly. And that's basically how that's how we should be integrating any service. So I've been looking at the various integrating of palliative care in acute care setup presentations, and tertiary care, primary level, and this is the other spectrum. So I don't want to repeat a lot of things that the previous speakers have mentioned, because it's pretty much the same. But I thought I should put across what should be done differently for the elderly, and what is it that we are doing differently for the elderly. So we have outpatient care for active and less sick patients who just come and visit us every fortnight or so. They're pretty active. They have although they have multiple illnesses, their quality of life is pretty good. They're doing quite well. They just need minor tweaking of medication here and there, and that's it. The other set of patients that come to us is patients who have had some acute episodes. Like I said, people who have had a fall and a fracture, and then they need some rehabilitation. They need some, good nursing care, good support, uh, and good medical supervision. We provide short-term respite for them. We also have daycare. Again, this was present pre-COVID times. Post-COVID times, they've stopped the daycare facility because obviously we don't want people to, be mixing around with each other at this current situation. But yes, that is a service which we were providing. So these would be active individuals who have nothing to do at home. Now, again, coming back to the nuclear nature of the family, if you have a small family, one son, one daughter, the parents are staying with the son maybe, and the son and his wife both are working. Now you probably have an elderly father or a mother, maybe both, most of the times not both, one of them, who are sitting at home idle and doing nothing, maybe just taking care of the child for some time. But again, the child is in daycare. So what do these elderly people do? And what happens is, this is something that we have seen is, in such situations, these people over a period of time somehow get sicker and sicker, less active. They're mentally down, they're psychologically down, and they finally start questioning the reason for their existence. So in daycare, this is what we do. We provide a place where the elderly can come together, people of similar age groups, similar interests, and they have a space to do things that they really love doing, and we kind of just help them and provide that kind of space. This is probably just like providing daycare for children, but this is slightly modified for the elderly. The other thing that we provide is long-term care for the sick and terminally ill patients. Like I said, as many of them have multiple disease conditions, chronic conditions, we have a lot of patients who are coming in with diseases like cancers, Alzheimer's, dementia, wherein the family can't take care of these people at home, and they're finding it really, really difficult, both physically, emotionally, and financially. So we provide services to them at hospital grade services at maybe old age home prices. That is what we are doing, and that's kind of helped a lot of people. So we have had patients who got discharged, felt better, and have fairly good quality of life. We also started providing home nursing, pre-COVID times, wherein we have trained nurses who are trained under us going into the patient's house and providing home-based care, both short-term and long-term. So we used to do home visits as well, but in patients who really needed, some kind of companionship, some kind of aid, medical supervision, some kind of medical help, we used to provide that as well. And then we used to have a lot of social and recreational activities on a regular basis. So these are basically the services that we offer. And like I said, the principles of palliative care is something that underlies whatever we do. We try and apply the knowledge that we have of palliative care, about adult palliative care, about the knowledge that we have about the various illnesses and how the medicines are working differently in these elderly. And we try to provide them the best possible quality of life. So just to go about how we kind of started this and how we did it, this is just putting across, like I said, I didn't want to repeat what the other speakers have been saying. I just thought I should put our model, because we felt that this is quite unique, that we have developed this model, and this is quite unique to the elderly population, and this is more culturally relevant to the population that we have in India. Yeah. So what we did is we have created a standalone medical facility that could cater to all inpatient care. Now, this was not like within a hospital. This was a separate nursing home that we kind of took over completely. And we had, like I said, 24 beds, and we would take care of patients who had some acute emergencies or had some situations which could not be managed at home. Although chunk of our patients, we try and manage them at home, like I said, about 80-85%, there is still that 15% of patients that we need to provide inpatient care, and that's what the standalone center provided. It was a proper hospital. We had all the accreditations, we had NABH. We made sure that we are providing all possible quality standards that we could offer to the patients. Yeah. And the main thing that we started off, like I said, create this medical facility. It should be able to cater to both acute and chronic needs. So we had a whole lot of consultants visiting us, who came on call basis. We had people like orthopedic surgeons, we had general surgeons, we had physicians, we had gastroenterologists. We've had that. In fact, in our facility, we've done a lot more procedures, I would say, which I have not done in the past. The number of procedures, interventions in the elderly that we have done in the last 2 years is much more than what I have done in the past, got done for my patients in the past, let's say 15 years or so. So, and we realize that, doing the right kind of intervention at the right possible time avoids a lot of problems and avoids a lot of complications, and therefore improves the quality of life significantly to the patients, patients and the family members. So, like I said, the services that we, developed, nothing was overnight. We kind of developed over a period of years, and many of these things that I mentioned were done systematically and organically, and most of it was with the experience that I picked up over the years working in Data Memorial, working in Shanti Avedna Sadan, working in the private corporate setups in Bombay. So I have seen, I would say, the best of all possible scenarios. May it be NGO, where we try to provide free care to the patient, to Tata Memorial, which is like a tertiary care setup, best of the facilities available, to a private hospital, corporate hospital, wherein people are coming in and paying from their pockets for services. So that is the reason why kind of we came back and thought, rather than us integrating into a hospital first, we should have a facility where we could manage the costs, because the financial burden is something that is very, very important, and that is something that needs to be mitigated. If it is if the cost of healthcare is economical and feasible, the families are also much open to get into procedures. Like we had this situation wherein we had an elderly patient who had a bleeding peptic ulcers, and most of their doctors that they visited said, no, he's too elderly. Let's just leave him and not do anything about it. Incidentally, he was coming to me for Alzheimer's and dementia. So we kind of saw what is happening. We treated it medically. It was quite bad. We got in a gastroenterologist to come in, give him, treat the patient with the H. pylori protocol and whatnot. After a couple of weeks, his kind of symptoms improved significantly, because we took the initiative to make sure that he's not basically bleeding out and getting frailer and frailer. So like I said, you could do a lot of things if you have the right kind of team, and that's, I think, our plus point. And with God's grace, I would say that we have developed a very good team of nurses, a very good team of the helpers, mama maushis, and specialists also. The specialists, we've been lucky enough to have people who have less aggressive, but at the same time a very clinically oriented, research based belief systems, wherein they will not get into things which are not really practical. At the same time, they would suggest things which are practical and which are result oriented. The other thing that we did is we basically took the service to the patient. So like I said, the home based care is something that we started off to begin with. So our people were there to see the patients, just like any other palliative care team. Our team would visit the patients every 10 days, 15 days, depending on what their requirement was. And we could tweak the medicines, change the medicines, get investigations done. pick up things early, so that problems are avoided. And I'm happy to say that many patients we've been able to pick up things which otherwise would have if left unattended could have caused a lot of morbidity to these patients. The other important thing that we are now doing is trying to integrate technology. Now in today's day and age, I think we should not be leaving technology. We should not be basically we should harness the power of technology, and we should use it in the best possible way in the scenario. So right now we are partnering with the companies which provide monitoring to patients who are bed bound at home. This could be devices which can detect falls without being too intrusive, without any cameras and stuff like that. So if you have an elderly patient who's at home alone, maybe in a room, and you have kept maybe helpers. So this is like pretty unique in Pune that I have seen, is that there are many elderly people staying in big homes all alone, and they have maybe one or two servants, and not the servants are not present with them 24/7. They are there to take care of things, and feed them, bathe them, and that's it. And some of the elderly that I know of really are sleeping in homes which are locked from the outside by the maids because they're bedridden. So, so we had this situation wherein there we had an elderly patient who fell down in the middle of the night and was on the floor for at least 4 to 5 hours. Poor fellow, he fell down, he broke a bone and he passed out. And, the maid found the patient, the elderly gentleman, on the floor next day morning with a massive bleed. Now, like I said, we have partnered with companies which provide monitoring devices which will detect a fall, which will give us an alert. So if we have patients like this in this unique situation when there is nobody around, this device is excellent. It will give notifications as soon as the patient falls down. It will give you an alert saying that your patient has fallen down, and that's it. And the minute we come to know, it kind of it alerts me and the family member. So yeah, either me or the family member can take the appropriate step to make sure that they're fine and that they're taken to the hospital, and precious time is not lost. Like again, 2 days back we saw this in the newspapers. It's probably COVID related, not related to chronic illnesses, where we saw a young mother who had nobody else in the family, died at home with an infant, and that infant was with the mother's dead body for at least 2 days, is what the police says. So these are very common situations what we've seen in the elderly also, people being alone, maids going in for a vacation, something happening, people found dead, or people found in medical emergencies or situations wherein it's been really bad, and help did not reach them at the right time. So we are partnering with companies and organizations which will help us to monitor patients vitals, and various things, so that it makes life easier for everyone. So now then, coming back to the major challenges for geriatric palliative care. Now this I picked up from a research paper, and unfortunately I did not put the reference. I'll put it at a later point of time. So this is what are the major challenges for geriatric palliative care in the West. This is a data paper from the US, if I'm not wrong, and they have said that we have to develop methodologically creative and ethically sound research to promote evidence-based care and teaching, and this is very true. We have to have enough research, enough and more research in this field to help us, provide more culturally relevant palliative care to our patients. The other thing is to promote responsible care and treatment decision making in the face of multiple complicating factors. Yeah, like they're like I said, their emotional capacity, their communication skills, their behavior problems, their decisional capacity, the capacity to make decisions, and obviously the extended disease trajectories. So we have to, we have to develop our program which is more culturally relevant, which is more relevant to the kind of patients that you see in your practice, and the implementation of coordinated continuous care despite increasing fragmentation and sectorization and specialization in healthcare. Now, this is something that we are seeing is, the specializations are getting more and more and more and more specific. So, the other day, not the other day, a couple of years back, my mom kind of had a small accident with a mixie, and she kind of nicked her finger. So I took her to the nearby hospital, not a very big hospital in Bombay, but they got a hand surgeon to look at it. And the guy comes in, says that I just operate this much. And he kind of came, he put in a small sutures here on the tip of the finger, and that's it. There's nothing bad. I think a simple surgeon could have done it, but we got a hand surgeon to look into it. So this is the situation in India, wherein we have all possible specialties available, but unfortunately it's so fragmented and so widespread. It's all over. I have had patients who, like for example, if you're from Bombay, or you're from any of the cities, you would know that every patient will have multiple specialists that they go to. They might be visiting doctors in different ends of the city. One of my patients in Bombay, who was with me here in Palace in Pune, was staying in Bandra, taking care of patient, one set of medications from Mahim, one set of medications from South Bombay, and one set of his general doctor was somebody sitting in Bandra. So what was happening is, like, polypharmacy was very, very strong, and he was popping pills like anything. He had some 20 tablets going on for instead of maybe 2 or 3 or maybe 4 at the most. So this is something important. I think as a whole we should have some kind of a system in which we can track all the medications, specifically in the elderly, because they cause a lot of problems because of the change physiology. Yeah. So this is again from the same paper as and the paper kind of tried to strategize how to address these problems, the problems that I mentioned earlier. And they said that geriatric palliative care research should be enhanced by specific funding programs, which obviously is not present in India, and specific patient registries. That is something that we can do. Have a patient registry for the elderly specifically, and try and collect the data. And this is something that I've been talking for quite some time. I think all of us in the Iapc also should be considering this, is sharing data. A lot of centers have a lot of data, like Karnashraya has a lot of data. The Cipla Foundation has got a lot of data. Kerala as a state has a lot of data. Shanti Avedna Southern has a lot of data. Now, these data is basically sitting individually, and very few of them are doing research. Like Shanti Avedna is, from whatever I know, is doing very minimal research. At the same time, Karnashraya has an entire research department and a team of research doing palliative care research. So this kind of discrepancy and the data which is sitting there is getting lost, is what I feel. And basically what we should be doing at this point of time is coming together, pulling in the information that we have, and try to develop that care models and treatment plans which are more relevant to our population, just like Tata Memorial is doing for cancer, just like other big hospitals are trying to do for other specialties. We should try to come together, pool in our resources, pool in our data, and try to develop our own treatment schedules, develop our own models, develop our own principles, I would say, and therefore do something that is more relevant and more has got higher impact to our society in general. Thank you. So I think now it's time for questions because almost 7:20.
Yeah, so Arun, can you please start taking questions?
Yes, Dr. Prince, thank you for that excellent presentation.
Thanks.
Very nice presentation. Yeah, and a lot of people are impressed with it. There are a lot of questions. We'll start from one end and see how much we can move.
Sure.
Okay, right. So the first thing is that can you suggest Indian foods or Indian habits which enhance better neurological aging?
So see now the food habits per se, if you see, there are very many people who believe that various food supplements are really going to help patients as far as aging nicely, healthy, and develop their mental capacity. Things like coconut oil. Now, I don't know. I've been reading this for quite some time. There are people who say that taking like a tablespoon of coconut oil twice a day is very, very good for Alzheimer's, people with Alzheimer's and dementia. Now, this can be debated, but I have seen people who have improved with it, and I have seen patients who've not really shown much difference. So it varies from patient to patient, but things like coconut oil, things like dry fruits, things like Indian food basically has a lot of superfoods in the things that we eat. In today's day and age, people are looking at superfoods from outside, like whether it is exotic vegetables or exotic grains from other countries. But I believe that there is enough and more things in our own culture, in our own food, the native food that we have, that enhances memory, enhances this thing. Other than food habits, I think the most important thing that I see mostly is people should be kept active, mentally active, physically active as much as possible. These two things are really important to, kind of keep Alzheimer's and dementia away as much as possible. Yeah.
Thank you, Dr. Prince. Next question is from Dr. Nagesima. Could you explain which care components in palliative care are different from a good geriatric care? Or in other words, what extra zinc does integration of palliative care add to good elderly care?
So now, sir, this is what we have seen is we in Dinanath Mangeshkar specifically, we had a department of geriatric medicine. We had very senior physicians taking care of the elderly, and they were in terms of clinical things, they were taking care of medical management was excellent. But when it comes to application of palliative care principles, basic principles about making sure how we can improve the quality of life, how we can avoid frequent admissions, how we can avoid polypharmacy, how we can avoid how we can basically counsel them and empower them with the information that is required. And I think that's the most important thing is doctors are there, healthcare is being provided everywhere, but many a times the patients are not told what this medicine is for and what to do in case something happens, and that's the most important thing I feel is to spend some time with the patient and tell them what their problem is, what could happen, and what to do when the problem appears. And that's, I think, the major difference, and that's the palliative care component that we can integrate into.
So if I appreciate that. If I want to just for the sake of an argument, say that bringing in principles of palliative care into any medical care improves the standard of care.
Absolutely.
Okay, but I would then argue and say that it is that talking to a patient is not palliative care. It is following palliative care principles.
Sure.
So when we talk, or the what I think the subject of this talk would have probably mean is that what aspect of palliative care is different as far as the geriatric community is concerned.
Okay.
That's what we no all the stuff that you're doing is absolutely superb. You know, teaching a guy how to do that, avoiding polypharmacy. I mean, you don't have to do it in palliative care only to avoid polypharmacy. You know what I'm saying?
Sure. So, sir, what I meant is like I kind of heard all the lecture series that was going on, the integrate series that we have. I think we have had like at least 3 talks before mine, wherein they were talking about integrating palliative care into acute care. They were talking about getting into acute care setups, and they were also talking about I think GPs, how to integrate general practitioners. So a lot of this was already spoken, and I really didn't want to repeat what was already spoken, because it's all the same thing. If you look at palliative care, it's basically good ethical medicine is what I believe. What we practice, all of us, is good ethical medicine and sensible medicine. I would say, not to overcomplicate things a lot, and whatever specialty we are dealing with, we should just go with those principles, and that will really improve what is, from what is currently happening. This is what I have seen, sir.
Thank you, Dr. Prince. We have very little time. People are asking for your contacts, which you have shared. Thank you.
Yes.
So we'll come to you, Stan, at the end. So last question before we go to Stan is that how did you make your organization cost effective? Because there was a question from Bangalore. How do you make it cost effective? And are there any help or any kind of schemes, from government which can help the elderly?
So the schemes basically, I think, vary from state to state. Every state has their own scheme, and we have to leverage whatever is available. In Maharashtra, unfortunately, there is a scheme available, but it is, if you look at it financially, it's the support is very meager. It really doesn't make much sense. It really just covers the basic medicines and stuff like that. It really doesn't cover anything more than that. But at the same time, there are many organizations which are willing to help. So when it comes to our organization, we are a private entity. Actually, we are a for-profit company. We believe, this is my firm belief, that palliative care should become a profit-making venture. It should become something that will give good livelihoods to people who practice palliative care. It should not remain only in that NGO kind of sphere, which what we see in 95% of cases in India. We should develop models over a period of time which is financially viable, which is which again goes a long way in helping the quality of care that we provide. We can enhance the quality of care. Like just to give you an example, look at Karunashraya. Karunashraya has got good funding. So Karunashraya has got a large team of qualified people taking care of business there. You have a whole wing of research, which I mentioned before, a whole set of taking care of, whole set of people taking care of academics. Now, NGO model, I think Karunashraya is uniquely successful there. But take out a few NGOs, you will see 90% of the other NGOs are really struggling for a day-to-day existence. They are just on shoestring budget, and they're just making ends meet. So they are not able to enhance the quality of care that they are giving today. So like Karunashraya, I'm sure, like I have visited Karunashraya so many times over the years. Karunashraya about 15 years ago was different, 10 years ago was different, and today is very, very different. I think Dr. Nagesh would agree with that. In terms of the number of people that you have on board, number of the projects that you guys are doing, number of initiatives that you started. So I firmly believe that it's difficult. It's very, very difficult to start something like this. A lot of my savings and my parents' savings have been put up in what I have kind of started. But it is showing, benefit now. 2 years down the line, 3 years down the line is when you start seeing the results of all the hard work. Now, I have been in palliative care and I've been in private practice in both in as in Bombay and in Pune. So I have seen how long it takes to kind of develop a specialty, to develop a team, and to develop a certain name within the community that, okay, you can go to so and so and he or she or his team will take care of the patient very well. So it takes a lot of time, takes a lot of effort, takes a lot of money, I should say, but it becomes viable over a period of time. It becomes viable, let's say 3 years from now, 5 years from now. And what I have seen is every city would have its unique situations, and we'll have to look at that and kind of tweak yourself to make sure that you're becoming viable.
Thank you so much for your practical inputs. Stan, it's your time.
Yeah. Thank you, Prince, for taking up this huge area of need. And maybe we should develop further the interest group in Iapc for this. One thing that I feel that this interdisciplinary integration can make a difference is, especially in a hospital situation where the geriatricians are doing excellent work, is to have combined clinics with them so that you can recognize, identify people early who need good palliative care, and
Right.
also develop what we call advanced care planning, and
Sure.
also the last, the last phase of life, because all of them are doing good work. And you know that in 2018, we had this Delhi declaration, with the Indian Academy of Geriatrics, Alzheimer's Society, and also the Helpage India. All of them are doing good work, but there is a gap in the end, where the person is bedbound at home, nobody to take care, and especially to achieve a good death, to make the death, the final bit possible, is where good palliative care can help.
Sure, sir. So exactly that's what we have done, sir. We like I said, one of the geriatricians in Dinanath Mangeshkar Hospital is the president of the Geriatric Society, and we have kind of linked up with him. We don't have joint OPDs because of time constraints and his OPD's time being different compared to being mine. But what we have kind of hoping to develop, and to some extent we have already developed, that is, he kind of refers us patients where he feels that there is that extra care, that extra support that is required, and that is how our network is also increasing, and that is how like I said, see, now this point has been already covered in, I think, the pediatric palliative care lecture by Spandana. Spandana kind of laid it out entirely, how they have developed the entire pediatric palliative care and how they have developed it. So I felt that a lot of it would have been same, rather than me saying the same thing, just putting geriatrics instead of pediatrics really doesn't make sense to the audience. And I felt that's why I should give what is more practical and what is more sensible according to me. I'm sure experts will have different opinions, and obviously more people thinking about the same problem will have more unique solutions also. So that's why even I feel that we should come together and develop a model which is something that is more viable pan India rather than being more specific to Maharashtra or Pune.
Right then, guys, it's 5 minutes past time, and I think what Stan said in the end is exactly a wonderful way of summarizing things. We've got a lot of things to do, a lot of things to learn, and it's wonderful that people like Prince John are working in this area. We should encourage more people, have a special interest group, all that. So till next week, all of you, please take care. And I hate to say this, but the situation is so bad. Please do all that you can to stay alive. That was the advice that was given to me by a couple of my very close friends. So God bless all of you. Take care.